Welcome to Lecture 11, based on the spinal cord. In this lecture, we'll be looking at the function and form of the spinal cord and how that relates to the relationship between the cortex of the brain and the function of the peripheral nervous system related to connection into the spinal cord. We start taking a look at the spinal cord with the brain. We have the cerebral cortex, or the gray matter that's on the outside of the brain. And we notice that the thalamus is highlighted here. The thalamus is the relay center for sensory information. And when we take a look at how the spinal cord is functioning, it's performing two tasks. It's relaying information from the body, sensory information, in an ascending fashion that is first cleared through the thalamus. The thalamus determines where the information needs to be routed to in the cortex, and then that information is sent from the thalamus to relevant regions within the cortex. The second function of the spinal cord is to take motor information from our precentral gyrus and take that motor information and go ahead and allow for somatic or visceral connectivity with the rest of our body and perform whatever functions we'd like to have performed based on what our motor cortex determined that we wanted to do. One of the things within the motor information, the efferent or exiting information, is that at the decussation of the pyramids within the medulla oblongata, at the decussation of the pyramids, we have a crossover of the corticospinal motor information. Cortico from the cortex, spinal into the spine. This is why when a person would have a stroke, say in the left hemisphere of the brain, we could see the right portion of the body affected. This information is crossing over here at the decussation of the pyramids. And then we'll dig into the spinal cord and take a look at it more formally for a few of the landmarks that we have within it. The spinal cord has very similar sectioning to the vertebra that we looked at. The only numbering difference that we really see is within the cervical spinal nerves. So whereas we were looking at 7 cervical vertebra in this region, we see 8 pairs of spinal nerves. So we just modify our reminder on this to breakfast at 8, lunch at 12, dinner at 5, and then 5 pairs of sacral spinal nerves and 1 pair of coccygeal spinal nerves. So the lumbar spinal nerves that we see are going to be servicing mostly the anterior portion of the lower extremities, and the sacral spinal nerves will be servicing mostly the posterior portion of the lower extremities. We see enlargements within the spinal cord that give rise typically to other more extensive output for the spinal cord. Here within the cervical enlargement, we see this give rise with a few of the cervical spinal nerves above to the brachial plexus, which we see will run the arms. And then we see the lumbar enlargement with some of the inferior portion of it giving rise to a lot of the function of the anterior portion of the lower extremities. Conus medullaris is considered to be the formal end of the spinal cord, and filum terminale runs from conus medullaris. It's a modification of pia mater, which actually anchors the spinal cord deep inside the sacral canal. Cauda equina is the fanning out of the nerves that come out of this most distal portion of the spinal cord. Cauda equina, cauda means tail and equina means horse. So these nerves, when they're dissected out, look like the tail of a horse. Here's a dissection where we see in this region we have conus medullaris, and so the cone actually is this portion here. So this is conus medullaris, and then it is attached onto filum terminale. So filum terminale then down here would be anchoring into that deepest point in the sacrum. And again, filum terminale is an extension of the pia mater that is the innermost covering of the spinal cord. Then you see cauda equina, the fanning out nerves, and cauda equina is then the tail of the horse. So cauda equina is running mostly through posterior sacral foramina to go ahead and service the posterior extremities. Here's another dissection where we see filum terminale. The sacrum has been dissected, and we see the muscle attached to that. Notice here this almost paper-looking item. This would be dura mater with arachnoid mater attached, and then pia mater would have been right up against this as well, and still probably exists, almost like the thickness of the final layer of an onion. Translucent, you can see through it. And then cauda equina is moved off to the side by these dissection pins so that we can more easily see filum terminale. Within the discussion of the spinal cord, we need to take a look at how does the white matter and the gray matter function. And if we have the gray matter being specific, say, to our motor activity and our sensory activity, then we're going to have these connections into it that are relevant only to motor and sensory input and output. So what are the names for this? How do they function? We see the spinal nerves exiting out of the intervertebral foramina, and in the ventral portion, we don't see a ganglia, whereas in the dorsal portion we do. Dorsal is sensory and ventral is motor. One of the things we discussed partially within our skeletal unit are the joints that exist in between vertebra. These intervertebral joints are comprised of a annular ring that goes around a more spongy form of fibrous cartilage. Every now and then, when there is an excessive amount of pressure put on these intervertebral discs, we can see a herniation or a rupture of those discs. Those herniations usually will push on the spinal nerve and cause the patient a lot of pain. One of the treatments for that can be a laminectomy, to actually remove the lamina and allow this spinal nerve to then flex into that new space and relieve pain. There are some treatments as well that can work on some of these herniations that have to do more with a mesh or a wire or extensive plastic mesh that can actually repair those as well. The meninges that cover the brain continue all the way down the spinal cord, and so we see the dura mater, and within this situation we reference the dura mater as the tough mother, and so dura means tough, mater means mother. The arachnoid mater is the spider mother, and the pia mater is the soft mother. These three meninges are, like I said, continuous from the brain, and they are critical in terms of containing cerebral spinal fluid and floating the spinal cord in the subarachnoid space. So we have cerebral spinal fluid circulating above the pia mater and below the arachnoid mater, and then removed from the meningeal layers in an area where we see the arachnoid villi, for instance, in the superior sagittal sinus of the brain. In this transverse section of the spinal cord, we can see a variety of items. We see the meninges, the dura mater, the arachnoid mater, and the pia mater in their locations. So as we come from a external or superficial position into a medial and a deep, we have those in the same position. We also notice in the subarachnoid space, so subarachnoid, just beneath the arachnoid, this space in here, this is where our cerebral spinal fluid is circulating. We see in the subarachnoid space these denticulate ligaments. The denticulate ligaments are holding the spinal cord in its position so we don't have excessive posterior or anterior or lateral movement of the spinal cord. You can imagine if we had excessive movement of the spinal cord beyond what is acceptable, that we could potentially have problems with our nerve connections or pain in the movement of those nerves. So although this is floating within a cerebral spinal fluid cushion, it's only allowed to move a certain amount. The epidural space, epi above, is the space where an epidural would be administered to a patient to allow for pain killing, say for instance within childbirth. When an epidural is added into this region, it's not going underneath the dura through a needle, but it is diffusing through because of the molecular size of the medicines that are administered. And we see within those medicines a variety of medicines like lidocaine or morphine. There are a variety of different painkillers that can be administered that have molecular sizes that will go ahead and diffuse through and then numb any of the nerve space below that region. In contrast to an epidural would be out in this region here. A spinal tap is actually going to go beneath the dura. So notice here where we're at. We're within a region of L4 to L5. We've almost begun our entry into the sacrum. And the reason why a spinal tap would be administered here is conus medullaris would have ended somewhere up around L1 to L2. We don't want to administer a spinal tap with the possibility of injuring the spinal cord. So the spinal tap is administered lower and cerebral spinal fluid is retrieved, and then we can assess the patient's health of their central nervous system in terms of, say, specifically if we were looking for something that the bacteria that could cause spinal meningitis, for instance. So spinal tap goes subdural, epidural does not go subdural. Here's a dissection of the spinal cord. We can see that the lamina and the spine of the vertebra have been removed, as well as a pretty good portion of the transverse processes. So in this dissection then we're able to see the various structures as they exist. This image then just corresponds with this photo. We have a cervical enlargement, so we know that we're in this range where we're in the cervical vertebra. Here we can see in this image the cervical enlargement, which is mostly contained within the cervical vertebra with a small amount in the beginning of the thoracic vertebra. We also can see within number 2 we have superior trunk of brachial plexus, the middle trunk of brachial plexus, inferior trunk in number 4, the first thoracic spinal ganglion in number 5. So again, a spinal ganglia would be in reference to a sensory input, whereas the brachial plexus contains a functional component, whereas the brachial plexus contains the functional component of motor activity. So these would be ventral. Number 6, the blood vessels in the subarachnoid space. So we can see this highly vascularized portion of this that gives rise to the name arachnoid or spider, because this looks like a convoluted spider's web. In this image, we have a really nice dissection where number 1, again, we can see that vascularization giving rise to the arachnoid mater. Number 2, this pearlescent, very strong covering in the dura mater. 3, 4, 5, we're not concerned with for this exam. 6, however, when we drop down into this region, we're right up against the spinal cord, and it's even hard to tell that there's a covering on it, but there is, and again, it's as thin as the final skin of an onion, and this would be pia mater. This is a really nice dissection that shows the removal of the gluteal muscles, the opening of the sacrum, and then we get a really nice view of these almost 45-degree angles that the spinal nerves exit in the intravertebral foramina. And then we can see down here cauda equina. We know that conus medullaris would be in this region, and filum terminale then extends all the way down. These elements over here are actually kidneys. When we take a look at a transverse section of the spinal cord, we want to pay attention to exactly where differences are within gray matter and white matter. So we need to take a look at those differences because they reverse in terms of how they're located on the brain. Some structures that we can see here, we see a posterior median sulcus. So remembering that sulcus doesn't go all the way through, it's just an indentation. And then we also see an anterior median fissure. So a fissure that would go all the way through this area. And these are just items that on a cross section we can see. We see that within the difference between gray matter and white matter, in gray matter, each one of these inclusions is actually a neuron. These are not myelinated, and it's the myelination that gives us the white matter look. So we have axons that are traveling out of all of these neurons, and once they have traveled out of the gray matter region, those axons are myelinated, and that's what gives us the white color within the spinal cord. Same thing is true for the brain. Some of our landmarks, these longer, slightly more slender horns are the dorsal horns. I always think of the S in dorsal horn as meaning sensory. So whenever I see an S, I just think S equals sensory. And if we're not sensory in the ventral, then in this horn region, then what we're looking at within here would be motor feed. We have sensory or afferent, ascending, and motor or efferent and exiting. Within this portion of the gray matter, this slide is just showing a close-up of a neuron. So here we can see the nucleus. Here we have cytoplasm. We've got these dendrites coming out here, and we have an axon coming out here. Specifically, this triangular region in here, this would be our axon hillock. So the axon hillock is where we're interested in having our action potentials begin. We only see lateral horns in the region of T1 to L2. And the reason for that, where we see just these lateral horns, is that within this region, we have a large amount of sympathetic output or management of the viscera. So if you think about the region of T1 to L2, you realize that within that region, we have a tremendous amount of viscera within our thoracic and abdominal pelvic cavities. And so wherever we see a larger output or management of a portion of the body, typically through skeletal muscle or increased sensory output, we're going to see more neurons involved in that relationship. And that's going to create larger inclusions in the spinal cord, like those enlargements that we saw before and the lateral horn, for instance. So here we can see a little bit more colorful model where, as I noted before, if we see dorsal, the S is sensory, which is afferent or ascending. If we're not sensory, we're left with motor. And within this, in the sensory portion, we have a somatosensory or body, and we also have a visceral sensory or organs, the sensation of our organs. Within the motor, we have the same visceral, and we also have a somatomotor. Management of the body, where we're managing the soma in the motor capacity, and then where we're managing the visceral motor capacity. Visceral motor is going to be autonomic, and somatomotor will be voluntary. And then here in sensory, we're either sensing the body or the viscera. We've been discussing the spinal cord and taking a look mostly at the gray matter that exists within the spinal cord. Now we need to take a look at the white matter that exists. These columns, which are transferring information to and from the cortex, are called funiculi. And so here is a posterior column. Then we would see lateral columns. And then within this, we would also see these anterior funiculi. And so whenever we see white matter, we know that we have myelination within these regions. And the myelination then is what is giving us the color differentiation from gray to white. We've been taking a look at this, and now we're seeing a slide of it. So it's kind of faint, but you can make out the gray matter horns. Here is one half of them. So in here we have gray matter. We have the central canal. we have our ventral horn, our dorsal horn, our white matter. We have our dura mater, and then we have our subdural space, and then we also have our arachnoid mater that we can see here. So then even deep to that would be our pia mater, that would be a layer that exists in a continuous fashion all along this region. All of the meninges, and then the distinction between white matter, gray matter, and the horns that are within that gray matter. For our sensory, if we're dorsal, we're feeding into this horn, so we're moving in this direction. In the sensory, or the dorsal portion of this, we have ganglia. So a dorsal root ganglion, a ganglion is a collection of neuronal bodies, and we see these enlargements when we have a large amount of input. That just means that we have more of these neurons that are processing information. In the ventral portion, we don't see a ganglia on the same portion of the root that we see this within the dorsal portion, but we have a slightly different structure off of the ventral portion, which is this sympathetic chain. So the sympathetic chain has these ganglia-type bulges within it, and the sympathetic chain is directly involved with our fight-or-flight response. And so when we need more rapid communication between portions of the body, we will tap into this sympathetic chain to send action potentials and recruit more portions of the body to get us out of harm's way. So dorsal being sensory, ventral being motor, and then this special sympathetic chain inclusion on the ventral, and the special dorsal root ganglia on the dorsal portion. Communicating rami are portions of this that are specific to just assistive communication to and from the chain. Another look at the dissection that we've been looking at just a little bit higher up. Here we can see foramen magnum. And so at foramen magnum, we have this exchange where we formally become spinal cord, and then up above we become medulla oblongata. These gracile tubercles and cuneate tubercles are transmission pathways that we see within the spinal cord, and the rest of this is not of specific interest for our exam, but it is these are important locations if you want to drill into the spinal cord in this capacity. Dermatomes are mappings of specific regions of the body and specific to the surface or the skin, which are supplied by sensory fibers from specific spinal nerves or spinal cord segments. What these are used for is, in a clinical facet, what we see is that if a patient comes in with usually, like, say, a spinal cord injury or some kind of a nerve injury, these are tools for assessment to where a patient will be touched in different portions of the dermatome, and whatever the lowest portion is that can be touched with sensation, then any portion below that that's touched without sensation, the dermatome just helps note which part of the spinal cord may be damaged if we're not getting sensory input from this particular region. So again, dermatomes are a clinical tool that can show damage to the spinal cord. Some of these dermatomes do overlap. That just is one of the things that we see with continuous nerve feed into certain portions of the body. Finally, we take a look at an interesting developmental test that can be applied to children. Up until about the age of 1, the myelination of the peripheral nervous system is still occurring. And until myelination has been completed, when a child's foot is stroked, the toes will fan upward. So when myelination is completed, we will see a proper plantar flexion, or the toes flexing down, when the base of the foot is stroked. We can see the fanning toes up until about the age of 1 in some children. After the age of 1, having a fanning up motion of the toes would be considered a concern in terms of damage that may have occurred to the motor pathways or the descending pathways that would run within this region. So following damage to descending motor pathways, stroking the sole of the foot causes an abnormal fanning of the toes and the extension of the big toe. And again, this would be abnormal after about the age of 1. Previous to the age of 1, stroking the base of a child's foot, we would expect to see the fanning toes.